Hi, everyone. Welcome to the webinar. We're going to wait a minute until we have more people filing into the Zoom room. So hang in there and we'll get started shortly. Hello, everyone. Thank you for joining us here today. I'm Linda Mitchell, CEO of Allergy and Asthma Network. Welcome to this afternoon's webinar. I'm delighted to have Dr. Kelly Maples here as today's webinar presenter. She's a real expert on eczema and skin of color. We have a few housekeeping items to go over with you before we start today's program. First, all participants will be on mute for the entire webinar. We will be recording today's webinar and we will post it on our website within a few days after this webinar has been completed. You all can always find our recorded webinars by going to allergyasthmanetwork.org. You can scroll to the bottom of the homepage and you find the recorded webinars and any upcoming webinars as well. This webinar will be 1 hour in length and includes time for questions at the end. We will take those questions, but during the whole session, you can put your Q&A questions in the Q&A box at any time. The Q&A box should be at the bottom of your screen. We have somebody monitoring both the chat and the Q&A, and we'll get to as many questions as we can before we conclude the session at 4 p.m. This Advances webinar is presented in partnership with the American College of Allergy, Asthma, and Immunology. The college offers CMEs for physicians and attendance credits for all others. You can create a free ACAAI account and obtain CME or attendance credits through the member portal of the Advances webinars. All attendees will be offered a certificate of attendance from allergyasthmanetwork.org as well. No other continuing education credit is provided. A few days after the webinar, you will receive an email with supplemental information and a link to download the certificate of attendance as well. And we will try to add a certificate of attendance in the chat. Sometimes it works with Zoom and sometimes it doesn't. So let's get started. Today's topic is atopic dermatitis and skin of color. Atopic dermatitis is more common and sometimes more severe in Black African American people and in Hispanic Latino people, especially children. Because of its unique appearance on skin of color, it is often misdiagnosed. It's vital that physicians and patients recognize symptoms in skin of color and understand how social and economic factors can impact diagnosis, management, and treatment in people of color. It's my pleasure to introduce our speaker, Dr. Kelly Maples. Dr. Maples is a full professor, congratulations, Dr. Maples, of pediatrics and internal medicine at Eastern Virginia Medical School. She teaches pediatric residents and cares for patients at Children's Hospital of the King's Daughters. Dr. Maples served a 3-year term on the Board of Regents for the American College of Allergy, Asthma, and Immunology, and a 1-year term on the ACAAI Executive Board. She has been the chair of the ACAAI Dermatology Committee for the last 6 years and serves as chair of the ACAAI Dermatology Scientific Council and the ACAAI Expert Committee on Atopic Dermatitis. Dr. Maples is committed to improving the care of atopic dermatitis in patients with skin of color and teaches residents and other allergists about this topic. She recently also worked with us to create the eczema and skinofcolor.org website with a team both at the college and with Allergy Asthma Network. Her team this team of producers run a 2022 Reagan Diversity Award for their work on this website. So thank you for being here today, Dr. Maples. I'll turn it over to you.
Thank you so much for having me. And thank you, everybody, for taking time out of your busy day to learn more about this very important topic. So once again, I'm Kelly Maples, and I'm from Norfolk, Virginia. I work at Children's Hospital of the King's Daughters, and I'm full-time faculty at Eastern Virginia Medical School. I have served as a speaker and consultant for AbbVie, but not since 2022. So here's our learning objectives for today. The first and kind of most important, I think, is to describe the clinical and physiologic differences of atopic dermatitis in patients with skin of color, and then use those to inform a treatment approach for those patients and discuss factors that can lead to disparities in atopic dermatitis care other than the different appearances in skin of color. So here's an outline of what I'm going to talk about today. First, I'll discuss the epidemiology of atopic dermatitis in patients with skin of color, and then we'll really focus a lot on clinical differences and images to help improve everyone's diagnostic skills. And we'll discuss treatment and then addressing other disparities that impact these patients as well. I want to take a brief moment to thank Dr. Andrew Alexis. I did a similar presentation for the Allergy and Asthma Network back in 2021. And when I was doing it, it was very hard to find clinical images of atopic dermatitis and skin of color. And I was kind of scrambling to make a good, meaningful presentation. And Dr. Alexis very generously lent me a lot of clinical images that I used for almost probably like 95% of the images for that presentation were from him. Fortunately, today, 3 years later, it's a lot easier to get good quality images of eczema and skin of color, but I have still used many of his images throughout, and I've indicated when they're from Dr. Alexis on my slides. If my images are from a publication, I'll cite it. And then there's a bunch of images where I don't have any citation, and they're from eczemaandskinofcolor.org, which I'll talk about more a bit later. So first, I'll talk about the epidemiology. So most of you listening know that atopic dermatitis is very common, and it's the most common skin disease in the general population. And eczema is more common in patients with skin of color than their white counterparts. And by 2050, more than half of the US population will have skin of color. So that means it's a really common problem that we really need to be able to manage and diagnose correctly. Eczema is more prevalent in patients with skin of color than in European Americans. And this is true for both pediatric and adult patients. So in children in the US, the prevalence of atopic dermatitis is 19.3% in Black children and 16.1% in white. But then just above that, you'll see the data in adults. There's even a bigger difference in adults, where the prevalence is about 19% in African Americans and only 3 to 4% in European American adults. In Asian countries, the prevalence in adults is 7 to 10%. Not only is eczema more common in patients with skin of color, but it's more bothersome, and they have higher healthcare utilization for atopic dermatitis, but not for other skin conditions. So Black and Asian patients, sorry, I'm going to move my picture on my Zoom. Black and Black and Asian patients in the United States are more likely to visit a doctor for atopic dermatitis than white patients with atopic dermatitis are. So Black patients with eczema have about 2 times as many visits for eczema, and Asian patients have about 6 times as many visits for eczema. But that's not because they're going to the doctor more in general. It's only specifically for atopic dermatitis. There was a 2002 study that looked at what percentage of US ambulatory visits were for what condition and from what population. And out of about 8 million visits for atopic dermatitis, 16% of those were for Asian and Pacific Islander patients, and about 20% of those were for African American patients. So when comparing to their white counterparts, Asian Americans had an odds ratio of 6.7. So 6.7 times more likely to visit a physician for their eczema than their white counterparts. And African American patients had an odds ratio of 3.4. Indigenous people were not included in this study, nor were Latino. So that's why I'm unfortunately unable to give you the data for that. Sorry, my slides are being, my slide won't advance. There we go. So I mentioned that although patients with skin of color go to the doctor more for atopic dermatitis, it's not because they go more to the doctors overall. And it's also not true for other skin conditions. So here on the graph, we see that for atopic dermatitis, that Asian patients in the gray bar and African American patients in the black bar do see physicians more often than their white counterparts. But if you look at other conditions here, such as warts and psoriasis and actinic keratosis, that's not the case. So they're not overutilizing healthcare in general. It's just that atopic dermatitis is impacting them more, that they're ending up using more healthcare. And we know that pruritus and xerosis, two of the most bothersome symptoms in patients with eczema, are more pronounced in African American patients and Asian patients with atopic dermatitis, likely leading to this increased healthcare utilizations for atopic dermatitis specifically. In addition to going to school, and in addition to going to the doctors more, they're missing a lot more school. So a US study of about 8,000 kids found that African American kids had about a 1.5-fold higher chance of missing 6 or more school days over a 6-month period than white children with eczema. So in addition to the loss of learning, which can be harmful for the child, this can also lead to loss of income for families, because when the child is unable to go to school, often mom or dad has to stay home from work. So it can have a huge impact on the quality of life of the entire family, not just of the child. The authors of that study concluded that atopic dermatitis has a greater impact on quality of life in Black children than their white counterparts. Another study of just over 400 pediatric patients with severe eczema found that 89% of them, so a very large portion of them, found that their social lives and their leisure activities were impacted because of their eczema, including things like avoiding athletics and outdoor activities. So in addition to affecting their quality of life, this is also starting to affect their exercise, which can have a huge impact on their health beyond just their skin and their sleep. So a lot of what I want to focus on today is clinical presentation. So the diagnosis of atopic dermatitis is a clinical one. So if you don't know what to look for, you might miss the diagnosis or underestimate the severity of a patient's disease. And both of these mistakes can lead to the undertreatment of atopic dermatitis in patients with skin of color. And we just talked about how this affects their quality of life, and they don't exercise, and they miss school, and they go to the doctors more and spend more on healthcare. So undertreatment can lead to suboptimal outcomes for our patients. So just this month, Jackie published a whole issue dedicated to disparities in healthcare, and they did address the underdiagnosis of atopic dermatitis, and they found that the lack of ability and training of providers in diagnosing atopic dermatitis in underrepresented minorities when it presents differently from other populations is what leads to underdiagnosis. So today, I hope to increase your ability to diagnose atopic dermatitis in patients with skin of color. Before I show clinical images and talk specifically about diagnosis, I'd like to start with just 2 little clinical vignettes. They're very brief. I'm not going to give any solutions. I just want to get you thinking about it and be honest with yourself about how you would diagnose this currently, and then let's see if your opinions change. We'll revisit these patients later on. So Jack is a 14-year-old young man, and he comes to you saying he's really itchy. He has dry, itchy patches on his arms and legs. He did go to his primary care doctor, who told him he had dry skin and told him to use petroleum jelly. And Jack's been really good about it. He doesn't like putting petroleum jelly on, but he does it after every bath. And he said it's still not working. He's still really itchy. He still has these patches. And in the photo in the bottom, you can see what his physical exam looks like. So how would you describe this? Does Jack have erythema? Does he have signs of active inflammation? Do you see xerosis? Does he have post-inflammatory hyperpigmentation? And what treatment would you recommend for this young man? And the next patient you see is Tracy. So she's a 27-year-old woman, and she has been so itchy. She's itchy all the time, but it bothers her the most at nighttime because she can't sleep, and it's starting to impact her job. She's been using sensitive skin soap. She uses free and clear detergent for her laundry. She applies a thick moisturizer as recommended by her primary care doctor a few times a day. But recently she's resorted to taking sleeping pills so that she can fall asleep. And here we see Tracy's physical exam. So take a look at that. Think about what you think. How would you describe her physical exam? And then maybe what treatment options would you recommend based on what your feeling is of, does she have atopic dermatitis? What's the severity of her atopic dermatitis? This is a quote from the National Eczema Association. So in the blue circle, you see a prompt that they gave parents of Black children. So I'm a parent of a Black child with eczema, and this is what I wish more dermatologists knew. And here's one example from their website. I won't read the whole thing, but to give you an idea, I wish more dermatologists knew that eczema in patients of color can present differently than it does in white patients. Instead of having red and visible areas of patchiness and dryness, it is usually more difficult to see symptoms of eczema due to our skin tones. So patients are aware of this, and I'm glad these things are on websites so patients realize that it is possible that they might go to the doctor and still be misinformed about what their child has or how severe their child's eczema is. So I'm going to start to head into the image portion of this presentation, but here's some main differences in the clinical presentation of atopic dermatitis, and it's most well defined for Black and Asian patients. Black patients tend to have violaceous or hyperpigmented patches and plaques, not so much red. Post-inflammatory hyperpigmentation and hypopigmentation are seen in Black patients with atopic dermatitis and can be more bothersome cosmetically to those patients than in patients with lighter skin. A papular and perifollicular morphology is very common in atopic dermatitis in patients with Black skin and is often missed, so we'll talk about how not to miss that. Patients with skin of color tend to have more xerosis than their counterparts with white skin who have atopic dermatitis. Denny Morgan lines are more common. Hyperlinear palms is a sign of skin barrier dysfunction in atopic dermatitis and is more common in patients with African American skin. Periorbital hyperpigmentation is often seen. Patients with Black skin who have atopic dermatitis often develop prurigo nodularis, sometimes from scratching and rubbing because they have increased pruritus. They can also develop lichen simplex chronicus. Lichen planus-like lesions are seen in patients with atopic dermatitis. All of these I'll show you photos of. Lichenification is more common in Black patients, and the distribution is different. It's not always that classic flexural involvement, but extensor and truncal involvement can be seen as well. So the message here is that we might see different colors, morphologies, and distributions in patients with Black skin than in their white counterparts. And in Asian patients, the lesions can often have a nummular appearance or really a true psoriasiform appearance with heaped up edges and borders. And their biopsies on histology look a lot like psoriasis as well. So one important part of diagnosing atopic dermatitis is the presence of erythema, and even our scoring guidelines, such as SCORAD, do rely on erythema. So the definition of erythema is abnormal redness of the skin or mucous membranes due to capillary congestion, as in inflammation. But if we just stop there and we just use red, we're going to miss the diagnosis in a lot of patients. Or patients who have severe disease aren't going to get the great systemic therapies that are available now if you underestimate their severity. So one pearl takeaway from this is that erythema does not equal redness. Erythema can be red, but it doesn't mean only red. So here on the left, we see a picture of the classic erythema that so many of us saw in medical school and textbooks and everywhere, where we see pink to red erythema from the increased blood flow. But on the right, we see Jack's arm, the patient from the first clinical vignette that I showed you. And he has increased erythema and congestion from inflammation, but he has a more gray appearance to his erythema. We do see that he has a lot of xerosis with white scale, and he has some follicular lesions as well. But right on this slide, the main thing I want you to focus on is just the difference in the way the erythema looks. You can also try to look for a patch of clear skin and then compare it with your eye to the area of involvement. And that can help you appreciate the erythema as well. So the pigments in his overlying skin make the erythema look a different color than erythema does in his white counterpart. And this is why it's so important to realize, so that when you are doing things like the investigator's validated assessment score or SCORAD, that you're not underestimating the severity of your patient's disease. And the concern is that this lack of clinical images of atopic dermatitis and skin of color is leading to a gap in medical education, not just of physicians and providers, but when patients are seeking advice online too, they might see this red thing and say, well, I don't have that, and not realize that they really do have erythema and they really do have eczema that needs to be treated. As many of you know, at the end of November of 2023, the Joint Task Force Atopic Dermatitis Guidelines came out, and I'm happy to say that there are multiple areas of the guidelines that are addressing disparities and even the definition of erythema. So this is directly from those guidelines. Atopic dermatitis can present with different morphologies, including papular, lichenoid, nummular, and follicular clinical forms, and extensor surface, eyelid, and inverse flexural involvement. Classic features such as erythema can vary among skin tones. Erythema reflects increased blood flow to superficial capillaries, and if its literal Greek meaning red is strictly followed, the diversity of atopic dermatitis presentations can be importantly underappreciated. Consistent with calls to improve representation of diverse ethnic backgrounds and skin tones in medicine and society, we define erythema to include transient skin alterations characteristic of active atopic dermatitis inflammation, including red, shades of brown, violaceous or gray appearances. So now erythema is officially defined in the case of atopic dermatitis to include all the different rainbow or spectrum of colors that may be seen in patients with skin of color. So this is not a scientific study, but I mentioned earlier in 2021, I did a presentation on the same topic. And these are just screenshots of my Google images. So the top one's erythema, eczema, skin of color, erythema eczema, erythema black skin. And these were the photos I got. So definitely not representative of the appearance of erythema in patients with skin of color. And then earlier this month, when I was getting my slides together for this presentation, I'm happy to say that these are the results I got. So this is a great example of all the different ways that erythema can look in patients with atopic dermatitis of skin of color. And down here, there's a little shout out to our eczema and skin of color website, which I'll tell you more about. I'm also happy to say that there's increased industry awareness of eczema and skin of color. And that's great because representation is important for our patients. So now they're seeing what their eczema may look at, even in the media, even if they're not actively trying to search for our website, they can still see that eczema and skin of color has a different presentation. So this is from a Aveeno ad showing patients, hey, your eczema might look a little bit different than those classic red spots. So we talked about how the skin color can be different, and now we want to talk about how the morphology can be different. So this patient with this little girl's belly, a lot of patients will say it's just follicular accentuation or just keratosis pilaris, and it's not keratosis pilaris. This is follicular eczema, and on biopsy, she does have a true spongiotic dermatitis, so it's not keratinization around her follicles. This might be the only presentation of atopic dermatitis, and this follicular eczema tends to be very itchy and often doesn't respond well to low potency topical corticosteroids. Sometimes you'll need a higher potency or an alternative medication like a topical calcineurin inhibitor. But it's important to realize that this is atopic dermatitis. It might be the only thing you see. You don't want to see that and just tell patients to use moisturizer, especially if they're suffering from pruritus or lack of sleep and they're scratching their skin, which can lead to risk for infection. We want to make sure that we address this morphology. So we don't want to miss erythema, but we don't want to miss this follicular appearance. This patient also has a follicular appearance with some excoriated papules and some follicular appearance, but it has more classic erythema and it's in the anacubital area, that area where people are really looking. So that patient is less likely to have his atopic dermatitis missed. So some reminders for the guidelines for the diagnosis of atopic dermatitis. The classic guidelines, the Hanifin and Rajka, have the three major criteria that you have to have here with the chronic, relapsing dermatitis, and a personal family history of allergy or atopy, along with pruritus. But on the minor criteria, you can see here I've outlined in red, is perifollicular accentuation. So that's not a new criteria for the diagnosis of atopic dermatitis. It's been around since those criteria. On here, we see other findings that are more common in patients with skin of color. So xerosis tends to be worse and more exaggerated in patients with skin of color and can cause more stigma. Patients don't want to appear ashy. Elevated serum IgE is seen in many patients with atopic dermatitis for sure, but it tends to be more elevated in patients with black skin. Denny Morgan lines and orbital darkening are also more common in patients with skin of color. Here's the diagnostic criteria for atopic dermatitis according to the American Academy of Dermatology. And my little star disappeared, but perifollicular lesions are also in their criteria as well. So in addition to looking for erythema and the classic scaly patches in the flexural areas, we also want to keep in mind that we may see truncal involvement with perifollicular lesions as well. Patients with African American skin often have a lichenoid appearance to their atopic dermatitis. This usually occurs on extensor surfaces. They don't have lichen planus, so they don't have genital involvement. They don't have oral or scalp lesions usually. It's usually on the extensor surfaces, as you see here. So we see round lichenoid plaques with a silvery appearance, and here we can see some brown to reddish brown erythema with these lichenoid lesions on this child's extensor surface of her upper extremity. So pigmentary changes can be very bothersome in patients with atopic dermatitis, but they're more cosmetically noticeable in patients with skin of color. So on the left, we see a patient who has some hypopigmentation from topical corticosteroids. And topical corticosteroids can definitely lead to this, but most hypopigmentation in patients with skin of color with eczema is not due to topical corticosteroids. Most of it is due to inflammation, rubbing, and excoriation. So on the right here, we see a patient who has depigmentation from years of excoriation and scratching. This can be prevented by treating eczema early. So if we don't miss the diagnosis and the severity and we get them on the right treatment, we can help prevent this. Once they do have pigmentary changes, using a good sunscreen is important. Because the areas of normal skin will continue to tan, but the hypopigmented or depigmented areas won't tan, so that summertime sun can make that area more pronounced and more cosmetically displeasing. So sunscreen is extra important. Many patients with African American skin who have atopic dermatitis develop this papulonodular appearance as well. So here we see a lot of brown to violet erythematous papules. And once again, we're on the extensor surface, not on the flexor surface. He has some confluent violaceous to brown erythematous papules on the extensor surface of his upper extremities. And it looks like some of them may have become excoriated as well. So it's another one to keep in mind. And sometimes these patients do develop true prurigo nodularis as well, which, as you know, controlling the itch of that can be quite difficult. Shifting to Asian patients, patients with Asian skin and atopic dermatitis have what's been labeled a blended phenotype between white patients with atopic dermatitis and those with psoriasis. So we see thick, scaly, circular plaques with raised edges. We see parakeratosis and epidermal thickening as well. Patients with Asian patients with atopic dermatitis tend to have more Th17 and Th22 cells, in addition to the classic Th2 cells in their in their skin biopsies of atopic dermatitis. Interleukin 22 and interleukin 19 are found more commonly there, and they're thought to induce the epidermal hyperplasia and parakeratosis that is seen in this psoriasiform appearance of atopic dermatitis in patients with Asian skin. So here is a comparison of an Asian patient with atopic dermatitis on the left and a European American patient with atopic dermatitis on the right. So on this patient, once again, we see truncal involvement, and truncal involvement is more common in Asian patients, but can certainly occur in white patients, as we see here. And this patient has like a brown to violet plaques with raised edges. Some of them are circular and nummular in appearance. We can see on the back here how raised they are, and in contrast to these larger areas of pink to red erythematous patches with excoriation on the extensor surfaces and trunk of this white individual. And here, if we look at their biopsy, we see that this Asian skin eczema biopsy looks a lot like psoriasis, with this thickened epidermis and those elongated pegs. Here's a graph showing the epidermal thickness is greater as well. Here's another great example of truncal involvement of psoriasiform atopic dermatitis in an Asian American adult. Here we see this one with this classic scaly appearance and nummular, circular, pink erythematous plaque with raised edges. And we see another plaque down here also with a fine scale overlying it and a raised border. This is very classic of Asian skin atopic dermatitis. Here we see pictures of an Asian, Caucasian, and African American babies with atopic dermatitis. This is a great illustration of the different way that erythema will appear in patients with lighter skin compared to patients with darker skin. We see that more violet to brown erythema in the patient with African American skin. And then here we see psoriasiform plaques compared to more diffuse pink patches in atopic dermatitis. And all of these patients will have increased Th2 cells on biopsy, but the Asian patients tend to have increased Th17 and Th22 cells, much like you would see in a psoriasis biopsy. And patients with atopic dermatitis all tend to have elevated IgE levels, but it's more pronounced in African American patients with atopic dermatitis, especially babies. Here's a few more comparisons. So here we just see classic psoriasis with long thickened epidermis. And if we compare that to the Asian skin, the biopsy will look very similar on histology as I showed you earlier. And once again, we see some of this classic truncal psoriasiform plaques on the torso of a patient with atopic dermatitis and Asian skin. The erythema looks quite different, and it's a different morphology than we see in this patient with African American skin, with this violet to brown erythematous patches, lichenification, and a little bit of follicular eczema. Th2 involvement is common in all the forms of atopic dermatitis, but is absent in psoriasis. And the Asian pattern of Th22 and Th17 cells is more similar to what we see over here in psoriasis. And then down at the bottom, we see filaggrin. So filaggrin gene is really important in skin barrier. And we know that skin barrier function is important in atopic dermatitis, and that patients with atopic dermatitis have skin barrier dysfunction. This leads to increased evaporative losses and transepidermal water loss, and then increased penetration of allergens, irritants, and infectious agents that kind of starts this cycle of atopic dermatitis. And filaggrin loss of function mutations are very common in European American patients with atopic dermatitis, but they are not common in African American patients. So European American patients have a 6-time higher likelihood of having a filaggrin mutation than a patient with atopic dermatitis with black skin. But patients with black skin still have all this barrier dysfunction. So there's definitely more than one gene that's coming into play. We just haven't identified a common one yet. Asian American patients do have some decrease in filaggrin, as you can see here. The mutations in filaggrin that have been identified in the Asian population are different and distinct from the mutations found in the European American patients with filaggrin mutations. Our new guidelines from the 2023 Joint Task Force do address North American Indigenous people. I don't have any specific photos to show you of North American Indigenous people, nor do I have many photos of Latino patients with atopic dermatitis. But I'm hoping if I'm invited back in 3 more years, I will have more photos, just like now I have a lot more photos of atopic dermatitis in black skin. But the guidelines do want to address healthcare disparities in North American Indigenous people. So the social determinants of health that affect eczema care in North American Indigenous people include the remote locations where they live, crowded housing conditions on reservations, and suboptimal access to health care. So to address these disparities, the Joint Task Force guidelines suggest actively and equitably engaging North American Indigenous people in research and policy making, and that's a theme we'll talk about more later, and also incorporating culturally sensitive decision making during clinical encounters. If you do care for North American Indigenous people, it's important to appreciate their ways of knowing when you're caring for them or if you're involving them in research practices. In the area which I live, I don't have any North American Indigenous patients. So now here's our gallery. I want to just have as many images as we can for everybody to see of atopic dermatitis and skin of color. So here on the left, once again, if we think about the location, it's on the extensor surface, and the morphology here is we see a lot of follicular and papular atopic dermatitis with a brown to violet erythema. On the right, once again, we see the extensor surface involvement, and we have a lot of different findings in this patient. So if we want to, once again, we're going to find a spot of clear skin so that we can compare the abnormal skin, and that helps you see the erythema. So up here on her upper thigh is kind of an area of clear skin. So we see here, she has a lot of brown erythematous like plaque with like overlying lichenification and a lot of excoriated papules. Up on her upper thigh, we see that typical follicular pattern and as well as some papular eczema as well. And we see some depigmentation on her lower extremities from her atopic dermatitis. Here's a slide, kind of just rainbows of erythema. And the picture on the bottom right is one of my favorite ones for demonstrating how different erythema can look. So this patient here, the erythema looks gray, and then it starts to look violet here to a pink. So we see a gray, violet, pink erythematous plaque with some overlying fine scale at the nape of their neck. This top right photo, we have that lichenoid appearance with these flat, scaly patches with brown to violaceous erythema, once again on the extensor surfaces. Similar findings here on the top left. And then on the bottom left, we see brown erythematous patches and plaques with overlying xerosis. We see some excoriated nodules as well as follicular lesions. Oh, someone just let my dogs in. I'm sorry, guys. On the next page, we see, I mentioned earlier that xerosis is more prominent in patients with atopic dermatitis. So here we see a lot of xerosis with thick scale. You might almost miss how erythematous she is if we couldn't see this little patch of clear skin. So always trying to look for the spot of clear skin can help you. And when you compare this area to this, we see that she definitely has a lot of brown erythema with lichenification, thick scale, as well as some follicular lesions. Here we see a child with the classic flexural involvement. It does still happen. And we see brown to reddish brown erythema with lichenification and papular lesions, as well as xerosis with fine scale. Here we see a similar finding, but with a lot more excoriation. And this child also has some follicular eczema here on her upper thighs. We talked about the xerosis is more significant cosmetically. It's more severe and more cosmetically significant. So we see a lot of xerosis with fine scale on a violaceous kind of erythematous base on the neck and some lichenification up here. This is a one that I don't think it would get missed as much. I think that the antecubital distribution helps people appreciate it. But some might still call that post-inflammatory hyperpigmentation. If we look at his clear skin, I think it does have like a violet red appearance to it. So I would call that a violet red erythematous patch. Here we see a baby. Once again, a good example of how the xerosis works in African-American patients with skin of color. There's not much clear skin in this photo to compare it to. We can maybe use the child's thumb and see that this child has brown erythematous, lichenified skin with thick scale over a large body surface area. Here we see kind of erythematous to violet erythema. Excuse me. Then the picture on the top right, I would call brown erythematous, lichenified plaque with overlying papules. And then this middle bracelet makes you think a little bit about contact dermatitis. And contact dermatitis does often occur in patients with atopic dermatitis, and I'll address that a bit later on. Here we see a lot of the nodular appearance. So here we can see some excoriated nodules surrounded by brown to violet erythema. Here we see more than one finding, some follicular eczema in the area I'm circling, depigmented areas, and then brown erythematous nodules on this extensor surface. Here on the hands, we see some depigmentation with dyshydrotic eczema and then nodules that are brown to pink erythema. Here we see some brown erythematous excoriated nodules and papules scattered over the extensor surfaces of this lower extremity. On the back here, I see a lichenified brown erythematous patch with an excoriated nodule and some areas of dyspigmentation from scratching. And on the rest of their back, we see some lichenification as well and some other scattered lesions. We talked about depigmentation and hypopigmentation. So here near this belt buckle, it does make us wonder if there's some concomitant allergic contact dermatitis as well, since it's right at the area of the abdomen that's overlying the belt buckle. But this is a good example of how the pigmentary changes are so much more prominent and bothersome, can be stigmatizing in patients with darker skin. On this patient's hand, we see a Latino patient with erythematous, lichenified patches, and then areas of hypopigmentation on the dorsum of the hand. Here's some classic violaceous erythema. So this is a violaceous erythematous plaque with excoriation, with lichenification, and then a few excoriated nodules there on the periphery. Oh, excuse me. And then here's an example of some red-brown erythematous patches on the extensor surface as well. So this is going back to Tracy, the patient you might remember from our second clinical vignette. So here's her picture when she came to you and she couldn't sleep and she was taking sleeping pills so she could go to work the next day. We can look for some little pockets of some clear skin and then really appreciate that she has a large body surface involvement of this like violaceous to gray erythematous plaques and patches. There's some excoriation on her back and some excoriated papules as well. And here's 9 months after starting dupilumab therapy. So it's excellent that she's improved and she's not itchy, but this really helps you compare her normal skin so that you don't miss that erythema. Because it'd be very easy to miss the erythema, not only because she has darker skin and it doesn't look red, but such a big body surface area is covered, it's hard to see those pockets of normal skin. So once again, I encourage you always to look for those pockets of normal skin, and that helps us not miss the erythema. Here's a teenager who has a violaceous, scaly patches around their neck with some lichenification, and then we have excoriated papules as well. This distribution around the neck is common in African American patients, but sometimes can be suspicious for allergic contact dermatitis as well. Here we see violet and gray shades of erythema, and with nodular appearance on the neck, chest, and abdomen of this gentleman. And next we'll switch over to treatment. So now we know to look for unique morphologies, unique shades of erythema, and different distributions than the classic flexural areas in patients with skin of color who have atopic dermatitis. So now that you know what they have, then you want to move on to treatment. So the new eczema guidelines say that although there may be different inflammatory responses and some different genetic differences, such as who has what filaggrin mutation in different racial groups with atopic dermatitis, that the treatment really isn't that different. So they state that principles of atopic dermatitis care remain similar for all skin types. Hence, although there is interest in understanding potential variation in the atopic dermatitis inflammatory response across race, ethnicity, or ancestry, the relevance of these findings to informing treatment selection is not clear. And so far, multiple agents display no differential treatment response across these groups. So currently, the treatment remains the same for everybody. The most important, I think to take away is that we don't want to miss who needs more aggressive treatment. So when we're treating them, first, we don't want to underestimate the severity or miss the diagnosis, and we want to avoid under treatment. Consider systemic therapy as early as you would for patients' counterparts. And you want to address skin barrier issues and xerosis. So we know that skin barrier dysfunction can worsen the xerosis and itch of atopic dermatitis. So you want to address bathing regimens with patients. A lot of patients have been informed that baths are bad for eczema. So we'll see patients who get a bath once a week or a sponge bath once a week. And that bad reputation that baths get is because a lot of things we put in the bathtub can be bad for atopic dermatitis. But if we bathe the right way, it can be helpful. So I recommend soap-free, detergent-free, and fragrance-free cleansers in the bath. So soap-free. The reason we recommend soap-free cleansers is because the alkaline pH of soap activates proteases that break down the outer layer of the stratum corneum. So the skin cells or corneocytes and the outer layer of the stratum corneum are held together by special connectors. They're called corneodesmosomes. And there's enzymes that break these down for normal healthy skin balance. So they're called proteases. So these proteases break down the corneodesmosomes between the skin cells. And the alkaline pH of soap actually activates those proteases so they can accelerate the skin breakdown. And in patients with eczema who already have inadequate skin barrier function, breaking down the skin barrier even more is not what we want to do. So that's why I recommend soap-free cleansers. Then detergent-free cleansers. So a lot of body care products make a lot of different bubbles, and usually sodium lauryl sulfate is the detergent doing that, but there are other detergents and cleansers as well. And they dissolve the lipid lamella portion of our skin barrier. So the lipid lamella is a layer of fats in our skin barrier that helps hold in water and prevent transepidermal water loss, but also keep allergens and irritants out. So sodium lauryl sulfate will dissolve all of that. And then fragrance-free, the reason we recommend that is because many fragrances are strong contact allergens, and then they can cause allergic contact dermatitis in patients with atopic dermatitis. So those are things that we could put in the tub that all make the eczema seem worse. So soap, detergent, and fragrance. So there's plenty of soap-free, detergent-free, unscented cleansers out there. Patients should get warm baths, not hot. They shouldn't rub with a loofah or a washcloth. Some patients think they can scrub their eczema away, so it's important they know that that will make their eczema worse. And then after the bath, they should use a good moisturizer. Ideally, they should use a thick cream or ointment-based moisturizer because they're more occlusive. But if they don't like the feel of them, they'll never use them. So it's important to find a moisturizer that your patient tolerates. In the appendix of the new Joint Task Force Atopic Dermatitis Guidelines, there's a great handout showing patients that the thicker, goopier ones are more effective, but sometimes the thinner lotion ones are more tolerable, to help them decide what's best for them. If they tolerate a thick one, that's best. But if they don't tolerate the thick one, using a lotion is still better than nothing after the bath. So using the bath rules and a moisturizer can help address the skin barrier and xerosis, and which are more pronounced in patients with skin of color. Then we want to target inflammation while avoiding overuse of potent topical corticosteroids. So I didn't say don't use topical corticosteroids. So many patients are worried about dyspigmentation and hypopigmentation in the skin of all of their patients, but especially patients with darker skin. And while if you overuse high potency steroids, this can occur, most of the dyspigmentation in atopic dermatitis is not from the use of topical corticosteroids. And if we undertreat their eczema, the post-inflammatory hyperpigmentation may be more exaggerated. We can help prevent that by using adequate amounts of topical corticosteroids or other topical anti-inflammatories. If the patient has concerns about topical steroids or you're concerned about using them, then you can consider topical calcineurin inhibitors, topical phosphodiesterase 4 inhibitors, or topical Janus kinase inhibitors in moderate to severe atopic dermatitis. Addressing dyspigmentation concerns with patients is important, letting them know that treating their eczema can prevent hyperpigmentation from inflammation, and it can also prevent hypopigmentation from scratching and excoriation, reminding them to use sunscreen to help make it less cosmetically noticeable in those summer months, and then controlling itch with good medications. And if these things aren't working, go to systemic therapy. Think about oral Janus kinase inhibitors or dupilumab therapy. So despite differences in atopic dermatitis, dupilumab has been shown to be effective across groups. I mentioned earlier how much better our patient Tracy got with dupilumab. Here's another gentleman who improved significantly with dupilumab therapy. Before I start dupilumab therapy or other systemic therapies such as Janus kinase inhibitors, I consider patch testing. Some patients with atopic dermatitis have concomitant allergic contact dermatitis, and they might have allergic sensitization to one of their topical corticosteroids or an ingredient in one of the personal care products they're using. And with patch testing, if you can identify that and help them avoid that allergen, they might have a significant improvement in their skin where they're not as interested in systemic therapies. So I think that's important. But when we're patch testing patients in skin of color, there are limitations. So recall the limitation of classic erythema when interpreting patch testing. This is obviously a patient with skin of color with a positive patch test, and she has lighter brown skin. So this area of erythema and induration is easy to appreciate, but some patients have much darker skin, and seeing erythema on patch testing can be hard. So always remember to palpate every single patch. Feel for that induration because that can be a sign. And then side lighting is also helpful to help you look for different changes in skin color that may reflect erythema as well as induration when you're interpreting patch testing in someone who has atopic dermatitis. So in addition to being aware of the diagnosis and helping to treat the patients, there's other things that impact the care of our atopic dermatitis patients. So just recently this month, the impact of socioeconomic factors on allergic diseases was published in JACI. And so there is scientific evidence that socioeconomic status disadvantaged patients, especially those living in poverty and those in underrepresented minorities, have significantly poorer allergic and immunologic disease-related health outcomes. And the authors concluded that lack of specialty care leads to decreased quality of care and management in atopic diseases. So there's a lot of factors that come together that lead to that less specialty care. So lots of patients don't have good transportation, and if they have limited transportation, they'll miss doctor's appointments or might have to reschedule them. It might delay them picking up their medicine from the pharmacy. Income poverty can certainly affect access to healthcare and health insurance. Some low-income families may live in areas that don't even have specialists, and they might skimp on their medications to make them last longer, or even avoid doctor's appointments so they don't get a bill. Environmental triggers can be worse. So patients with lower socioeconomic status who might live in substandard housing might be exposed to more potential eczema triggers, including dust mites and tobacco smoke. If they don't have air conditioning, that can worsen their atopic dermatitis and their asthma in the summer. There's educational inequality. So there's a lack of knowledge and understanding about their skin condition that can lead to problems such as using medications incorrectly or not following through on treatment. If they don't know what eczema looks like in their own skin, they might not realize. So we can help educate our patients as well. That's why sharing resources with them that I'll mention to you later are important. And then language and cultural differences. So people who speak Spanish as their primary language might struggle to get appropriate health services or to fully understand their treatment plan. So the Asthma and Allergy Network on their website has Spanish language handouts, not only for atopic dermatitis, but for asthma and other atopic conditions as well. So if you don't have Spanish language handouts in your clinic, that's a great resource for you so that you can really help your patients. And then this is a little diagram showing how that the patient, the provider, the community, and policymakers affect the 5 aspects of quality healthcare, which are availability, accommodation, affordability, accessibility, and acceptability. So patient factors can include their income and health literacy, their education, stress and depression. So patients in high stress areas with low socioeconomic status and poverty have more depression and stress. So thinking about things like eczema skincare can be overwhelming and can affect their care as well. In providers, there's implicit bias. There's lack of training. We might not know that that little girl with follicular eczema needs to be treated. We may not realize that those patches are active eczema and not post-inflammatory hyperpigmentation. So we can continue to try to better ourselves, but we need more diversity in clinical trials. All the studies shouldn't be done only in white patients. Their community can affect them. So if they have, they live in substandard housing, we mentioned they have worse exposures to known triggers for their asthma and their eczema. And we should continue to vote and advocate for our patients to have policymakers to help with structural changes that can lead to improved care. And here's another set of recommendations. So the college did a survey of members, I think 200 responded, and they had a roundtable as well. It's called Proposed Solutions by the college and advocacy experts to address racial disparities in atopic dermatitis and food allergy. So they asked specialists, what problems lead to inadequate care in your eczema and food allergy patients? So it's a great study, but realize these are already patients who had access to a member of the college to be one of their caretakers. So they already have access to specialist care. They're already more fortunate than a lot of patients. But these are what they list. So 69% said access to a specialist who takes Medicaid. So I encourage you to consider doing that if possible, but we need our policymakers to make it possible for doctors to continue to accept Medicaid so that our patients can have access to care. Lack of awareness and education about their symptoms and conditions. So we can do our best to educate our patients and give them handouts that they're able to read at their grade level and in their language. Inadequate insurance, costs associated with treatments. Here's an important one. Access to a specialist near their home who has experience recognizing atopic dermatitis in Black and brown skin. So hopefully all of you can do that, and you can continue to spread this. So a lot of you teach medical students or PA students or nurse practitioner students. Teach them that. When you show them patients with eczema, show them images of eczema and skin of color. Continue to help with that because that's something we can do. And then the bottom of these are all important, but they're more pertinent to atopic dermatitis. So the recommendations from the survey and roundtable were to identify ways to recruit more people with skin of color into clinical trials and medical school. Because representation doesn't just matter on a website with pictures of skin of color. Representation matters seeing their healthcare providers look like them. Educate healthcare providers about the diagnosis and treating atopic dermatitis in people with skin of color. Develop culturally appropriate materials for patients and strive for longer appointment times for patients who need them. The 2023 guidelines made the following recommendations as well. Given the complex factors driving disparities, improved research and educational initiatives alongside interdisciplinary and multi-stakeholder involvement are needed to help reduce gaps in care. At individual and population levels, clinicians hoping to achieve optimal atopic dermatitis outcomes will actively address unconscious implicit biases and account for patient contextual factors in shared decision-making. Clinicians should also promote structural and organizational change. Consistent with this, a major theme of the guidelines is promoting equity, diversity, and inclusiveness. So Eczema and Skin of Color is a website that we started after I did my presentation in 2021. It's just eczemaandskinofcolor.org. There's a gallery. A lot of the images I showed today in the gallery come from that resource. If you have other images that you would like to add to the gallery, let us know. That would be awesome. In addition to being a resource for you and your medical students, it's also a great resource for patients. Patients have been appreciative when I show them the website, and it helps them know what eczema might look like in their own skin. And there's some recordings of different experts talking about eczema and skin of color for them or you to watch. So in summary, atopic dermatitis is more common in skin of color, so we need to be able to take care of it in patients with skin and color. It prevents with different colors and morphologies, as well as different anatomic distributions. It tends to cause more symptoms, more itching, more xerosis, more need for atopic dermatitis related healthcare. We really want to make sure we don't miss the diagnosis or undertreat, so make sure you're aware of all the different ways it can look. And we need to do more still to address healthcare disparity in atopic dermatitis and other atopic diseases. So thank you so much for having me. Thank you to the college. Thank you to Asthma and Allergy Network, not just for having me today, but for supporting eczema and skin of color. And now I'm happy to take questions.
Thank you, Dr. Maples. That was really wonderful. We got some really great comments in the chat about how informative this has been. And, it's just a really much needed topic. And we're just so glad that you take the lead on teaching so much about this topic. So I have some questions. I'll try to do a rapid fire since we're really close to 5 o'clock. We have a lot of school nurses in the audience who have students who probably have undiagnosed eczema or are living with the pain and itch of eczema. Can you kind of give some pointers to what school nurses can do to support these students?
I think, it's very hard, even if they know they have it, making a diagnosis and recommending formal treatment, but talking to their parents, sharing handouts from the Asthma and Allergy Network website, sharing pictures, the website of eczema and skin of color, talking about some basic skincare. I know they can't give medical advice, but even just good thick emollients after the bath, and then maybe seeking additional care from their primary care doctor if skincare recommendations aren't helpful.
That's wonderful. Thank you so much. So we got some questions here. So let me see. What is a good emollient to use, or can you recommend a detergent-free cleanser that is commonly used?
I like CeraVe cream a lot as a moisturizer. It is a cream-based moisturizer, not a lotion, so it's occlusive, but it's not super slimy. So I like that a lot because if it's too slimy, the patients don't like it. In addition, CeraVe has ceramides in it, cholesterol, and hyaluronic acid. There are 3 parts of that lipid lamella, that part of the skin barrier that helps hold water in and keep irritants out. So I like that one. It's also fragrance-free. It doesn't have a lot of the most common contact allergens. I also like Vanicream. I do not recommend using Aquaphor in little kids, especially under 3. It's nice and thick and occlusive, but it has lanolin in it. And lanolin is another strong contact sensitizer, and that can cause allergic contact dermatitis, which a lot of times looks like atopic derm. So they're putting the lanolin on those spots that bother them, and they're not getting better. And it's not because the eczema is bad, but it's because now they're allergic to their moisturizer. So lanolin-free, fragrance-free, I recommend. Vino Eczema Balm is another really good one. If they don't like creams, then just CeraVe lotion's okay, but I do prefer the cream if they tolerate it. Vaseline itself is not a moisturizer, believe it or not. It is occlusive, so if you just put Vaseline on right after the bath, it will help hold some water in and prevent transepidermal water loss, but it's not adding any emollients to the skin. So it's very affordable, and if that's all your patient can afford, putting that on after the bath can be helpful, but I would prefer Cetaphil cream, Vanicream, CeraVe cream, or Aveeno eczema balm.
Okay, thank you. You answered another question that somebody was asking about Vaseline.
Oh,
So,
and soap-free cleansers. CeraVe makes a bunch of soap-free cleansers, both in bar and body wash. Burt's Bees Baby Bee is soap-free. Vanicream, Cetaphil, Aveeno. A lot of those same brands make good soap-free cleansers.
okay, somebody just put something in the chat. Let me see. I don't know if I understand the question. Maybe you will. My question is about CARD11 mutation and the risk of developing psoriasis-like pictures after dupilumab. Does that make sense to you?
I've only read a little bit about it, so I don't think I'm expert enough to. I'm aware of people developing that after dupilumab, and other different dermatitis, like different dermatitis rashes, have developed in patients with it. But I can't speak to the evidence with CARD11 mutations specifically with that.
Okay. Why do we use eczema and the term AD interchangeably when some people with eczema have no allergy history?
Well, eczema is really not equivalent to atopic dermatitis. Like someone could have an eczematous rash and it doesn't mean they actually have atopic dermatitis. So like in the major diagnostic criteria for true atopic dermatitis, a personal or family history of atopy is one of the major diagnostic criteria. But sometimes people might just get like a dry, scaly rash that might be like an irritant contact dermatitis. It could be an allergic contact dermatitis. So when doctors say eczema, like we might be the finding on the skin, but not the diagnosis or the cause of the rash.
Okay, thank you very much. Well, it's a little past 5 o'clock. I just want to thank you so much for this wonderful presentation. And we really learned a lot today. And it's just really an important topic that we need to make more people aware of so that they can get people who have eczema and skin of color or atopic dermatitis and skin of color can get the diagnosis and treatment that they need. So I'm going to say thank you again, and I'm going to go ahead and move on to just closing up for the day. We have 2 webinars coming up later this month. Dr. Alice Hoyt will present spring allergies and asthma on March 14th at 12 p.m. So if you want to join us at lunchtime, we'll be here with Dr. Ann Hoyt, Alice Hoyt, and then we'll welcome Dr. David Golden on March 21st at 12 p.m. to talk about insect sting and venom allergies. So please join us for either of those. They're both wonderful speakers. Again, you'll receive an email from Zoom in a few days with a link to the recording. An evaluation will follow after you close out of Zoom, and supplemental resources will arrive by email as well. Thank you again from all of us here at Allergy and Asthma Network. Join us as we work every day to improve the quality of life and health for people with asthma, allergies, and related conditions. Bye, everybody.
Bye-bye.